over the quiz, Arnold. So Aiden, if you can put the quiz up for me, I'll do that. And Rebecca, just to try to help you there a little bit, is this material probably is with regard to the um, this material is probably the most complicated material of all of the stuff there, and you just think about how we're simplifying it'll go there, and that I think will help you a little bit. The other thing is having a little bit of time to maybe look over it at a slower pace. And this goes also from a standpoint of any of you, as you're looking over the material, do not hesitate to email me if I can give you some more, help you get through some of this. But again, the tendency with this type of materials, as I told you, when I took it, it just seemed like it was one of the most complicated things. But it does, if you think about simplifying, it will, when you have time to digest and look it over, it will help you out a little bit. Okay. Let's look at the questions for the quiz here. So one is let's see. That there is no question that it is going. I mean, this is not something that I anticipate you guys, walking out of here at the end of this weekend and saying, "Oh, that was clear as clear as can be." It does take a little bit of time to think through it, and you should find that there will be a point where it's like you see all of these issues and you see all of these things that these drugs can interact with and so forth. But again, if you think about those pathways and look through those, basically it will start clicking a little bit better, but it may take you 2 or 3 times to go through it. And if the tendency is to try to make it more complicated than it is. So we'll try to so the way I went over it is a good simplification, and that would go. And we don't have a text that really covers the most of this material. There is, I'm drawing a blank on the particular one. There is one that does help a little bit. I will see if I can remember the name of it before we leave today. And if you want to look that up, but there's a couple of papers that I have thought about, given to you, but the more I looked at them, they were more complicated than simplification there. So, but I will see if there's some additional material that would go through. I actually looked for some videos there may be a lecture by Kahn from the Kahn Institute, and I'll see if that's available. If it is, I'll make it available. The one that I did see seemed pretty detailed, and I'm not sure it gave any clarification, but I'll see if I can find something there. So, and Arnold said psychiatry volumes 1 through 3 will probably cover it, and then they probably would say that's out of date too. So, okay, so let's go over the quiz. All right, so number 1, which of the following does not block serotonin receptors as part of its therapeutic action? So the easy thing to think about is you've got 3 drugs that are atypical drugs, which are clozaril, risperidone, and olanzapine. And we know that the atypical drugs do block serotonin, and you've got one drug, which is a typical or conventional drug. And remember what we talked about this morning is all of those conventional drugs primarily works by the dopamine, blocking the dopamine receptors. And that's the advantage of the new atypical drugs, is that they block the serotonin. Okay, so a key point, probably we'll see something similar to that on future tests. Let's just put it that way. Question 2, movement disorders are associated with an interaction, which of the following? You got a little bit of this yesterday. Again, the thing is, when you talk about movement disorders, the biggest issue with the movement disorders is basically a scenario where think of basal ganglia, nigrostriatal pathway, Parkinsonism, and all of those are due to lesions in that area. So the correct answer is C. By the way, the correct answer on the first one was D, thioridazine. So movement disorders are due to the interaction at the nigrostriatal pathway. So question number 2, correct answer is C. Question 3, low potency conventional antipsychotics have more anticholinergic activity than high potency agents, and the correct answer is A is true. The low potency don't affect the D receptor or affect the dopamine receptor. They don't bind as tightly, but they also have more anticholinergic and antihistaminergic. You know, one way you might think about that is if the receptor binds loosely, then it may easily bind other receptors. So to summarize, the answers are question number 1, thioridazine does not block serotonin receptors, so that is D as in dog. Question number 2, the movement disorders are associated with interaction in the C nigrostriatal pathway. And question number 3, low potency conventional antipsychotics have more anticholinergic than high potency agents. Correct answer. Okay, so let's move a little bit more, and I'm gonna cover just a little bit of information, but you might want to get your case study in front of you, and because let me cover a little bit of material, and then we will talk about the case study, and then I'm going to give you another wrinkle on the case study for you to take a few minutes to think about how you would handle it. One of the things to think about when you're doing case studies, when you're working at patients, is sort of have your first plan. This is the way I want to go. This is what I'll do. And then think about with the second plan, I mean, what happens if this doesn't work, where I'm going to go? So we're going to come back with a little twist on your case study and then give you a few minutes. So when we take our break, I'm going to give you, we'll have a normally 10-minute break. You'll have about another 10 minutes to think about how you're going to address it. All right. Now, a bunch of these slides, you do not have to worry too much about. They're information primarily. I'm going to point out a few things. I actually had developed a bunch of these slides for some of the school psychologists. I did this nice thing of trying to develop these slides to have them so they can have a reference when they're out in the field. And I was going to put it on, have it set up so that we could interact and that they would have new information. I could update it and so forth. They all had computers. And then after I got all this stuff worked up, what came back was, oh, well, we have computers, but we don't have Wi-Fi in a lot of the areas that we're at. Okay. So some of these slides I found useful and put them in this sort of a reference to you. You can get much of this information from the PDR, or you can get some of it actually from the like Hippocrates. My youngest daughter did a lot to pull the pictures and stuff like that on this one. But risperidone, notice we've got, I just want to point out a few things, and again, nothing's in red, so you don't have to worry about these, but just to give you reference, is we do see that there's multiple doses anyway from 0.25 all the way up to 4 milligram, but we also have a orally disintegrating tab. Now, this is something that we've seen with some of the antipsychotics is a few of these products will have a quick dissolving tab. This one, in this case, is called the M-tab. So the idea with this is that it will, if people have difficulty swallowing the pill, or sometimes you have trouble getting pill down individuals, that it basically will quickly dissolve and break down in the mouth, and then it's easier to swallow. There is also an oral solution, and I've given you some pictures of what the different things look like. The M-tab is sort of square. The one thing that typically many times the recommendation is start with about 1 milligram twice a day, and then increase it on the next 2 or 3 days a little bit. But as with most of these drugs, we're going to try to use the lowest effective dose for maintenance. When we're switching from another drug, we try to minimize the overlap. There's a lot of different strategies for patients to switch from one drug to the other, and you will find different people like different things. Generally, one of the problems is that when you're switching from one antipsychotic to another, is since most of them are going to have general actions on the dopaminergic, is in making that switch, you want to try to minimize it so you don't get too much dopaminergic blockade. The typically, one of the things that I did put with risperidone is the elderly do seem to be sensitive, and usually we're going to look at a dosage reduction in the elderly. One of the things is to use about what you would normally use in a patient. Basically, use about half of that over and split up with BID in an elderly patient. Now, here's some key drug interactions. And by the way, when we talk about bipolar, I think I'll see you guys in 2 weeks. And I think there's a Saturday, if I'm not mistaken, that will be recorded because I have a conflict, but we will be meeting on the Sunday. And so I will give you the recording and we'll make that available at a much, the following week. I think it's the 26th, if I'm not mistaken. I will try to get the recording for that bipolar week to you guys earlier. So, do we have it? Okay. So next week is class. Then if it's next week, then I won't be doing a recording. I was confused with regard to the, with all the schedule changes. So then forget what I said. Next week we will be, we'll be discussing live. So one of the things that we see, I was going to go back and check my schedule, but I hadn't checked what we ended up with to make sure it was clear on mine. All right, so we will talk about drug interactions, and so we'll talk about some of these in general. One of the things with all drugs to think about is, put this in the back of your mind, is anticonvulsants. Okay, with anticonvulsants, basically many of those, carbamazepine, some of the other ones that we use, phenytoin and stuff, these will often result in metabolism induction. So basically what we're going to see is that that when we have that induction, basically what's going to happen is that you're going to have a faster. So one of the things that can happen is if the person is on carbamazepine, it's going to increase the metabolism of risperidone. So the clearance, it's going to be cleared through the body quicker, so the result of the action may be less. Fluoxetine can actually double or triple the values. That is an inhibitory aspect. And clozapine may also decrease clearance. So one of the things that you have to be careful about is potential drug interactions with risperidone. Of course, with the carbamazepine, the type of thing that I'm going to, would look at would be that I'm going to think about it's going to potentially be subtherapeutic. The drug may seem to stop working if they're on carbamazepine. With fluoxetine, I'm going to need to really be careful because if they're on fluoxetine or clozapine, one of the things that can happen is we can get more toxicity. So again, when you do a normal drug interaction, and the pharmacy should do this also, but you should also do this too, is one of the things that you should do is to basically double check to make sure there's no drug interactions. When we're counseling the patients with risperidone, we find that sometimes we have had, especially in elderly patients, when they first start, they may have some syncope. So especially elderly, be careful with that. We want people to avoid alcohol when they're taking this, and that's probably a good thing to do with most schizophrenics since there is a potential for substance abuse. One of the big things, if you do prescribe these M-tabs, I thought this was on an earlier slide, but I knew I had it in here. Any of these orally disintegrating tabs, they are very fragile. They will break down very quickly. So one of the things is you don't want someone to take them out of the blister pack and put them in one of these pill carriers, because what will happen is the tablet will start breaking down. Tablet can absorb some water. So they want to be left in the blister pack if you're doing this, and it's a good thing to counsel the patients to make sure that they understand this. The other thing is when we're trying to pop pills out, we try to push them through the blister pack. If you do that with these M-tabs, they typically crumble up. So it's a good thing. The pharmacy will usually do that, but I usually tell people the prescriber as well as the pharmacist should both, if the patient is hearing it from both people, you're sure they get the information. So you don't want them to try any of these orally disintegrating tabs, whether it's risperidone or the other one. They are pretty fragile, and so you don't want to try to push them through the tab, and you don't want to take them out of the blister pack until you're ready to use them. So with risperidone, our advantages are we do see effects on positive and some effects on negative. You're going to see that there's a common thing with a lot of these. Risperidone, well, all the atypicals, we will have potentially an effect on the negative symptoms, which is usually not the case with the typical drugs. So the atypicals will do that. This works pretty well if you use low dosage in geriatric patients. Minimal sedating. We can get by with once a day dosing sometimes. Typically less EPS and less tardive dyskinesia than we see with the typical agents. So those are some of the advantages with that. And again, early on, there was a cost issue compared to some of the others, but a lot of times the cost issue, because of the advantages we got, the cost issue may have been justified. The downside, orthostatic hypotension. So again, this is not, the main question is in the elderly, and that's primarily that, or people that may have some cardiovascular condition. And what we're going to do is we're going to basically tell them to take their time. You know, when you're getting up or changing positions, sometimes patients have complained, or the clinicians have thought that we need a little bit more sedation with the risperidone. Some people have suggested that compared to the other atypicals, EPS may be a little bit more common with this drug than other atypicals. In my opinion, you're going to be looking for it anyway. And so just if you're on the verge of looking at it or basically are being cognizant of everything, then you're going to get by. We can sometimes get by with once a day dosing, but a lot of times we have to use twice a day. And, we end up titrating the drug usually initially. It's not one of these drugs we just hit them with a big dose and let them go with that. Olanzapine, notice we have also a number of dosages here, 2.5 up to 20 milligrams. Anytime we have a large number of dosages, the nice thing about that is that it gives us a lot of flexibility. You would ideally like, with most of these drugs, a minimum of about 4 doses, maybe 5. This one has got 1, 2, 3, 4, 5, 6 doses. Really gives us a good ability to be able to tailor the dosage for the particular patient. They don't have an M-tab, but they have a similar product called Zydis. It is a yellow orally disintegrating tab. 2 doses of it. We have a 15 milligram at the top. On the bottom here, you see there's actually a 5, 10, 15, and 20 milligram. We also have powder for injection. So if we need to do an injection, we have 10 milligrams, and we can make it as dilute or concentrated as we need to by having the pharmacist reconstitute that for injection. Typically we see, and again, realize as you're going through these slides that if there's not red there, that's not what I'm going to direct. You're not going to be asked about that. Typically we're going to see starting off about 10 milligrams once a day. Although we may see people increasing the dosage, it's recommended that you give about 7 days, and hopefully you're somewhere between 10 to 15 milligrams. That's what most people would suggest. Elderly patients, people that have low blood pressure would be another group. You might want to use a lower dose because this can cause some orthostatic hypotension and drop it. They have used this for agitation. They've given IM injections, and then they can give 2-hour intervals if necessary for that. Think of before these drugs, our only injectable really was haloperidol. So this drug tends to be a little bit more sedating. And so, but with all of these drugs, there may be some sedation in some patients. So if other CNS depressants are used, you can get sort of an additive effect. Omeprazole can actually increase the clearance. So that is a over-the-counter acid reducer. So you want to be careful if they have that. Fluvoxamine can decrease elimination, so we can have a buildup. And we see that carbamazepine can also increase the clearance. So again, the anticonvulsants kick in there. Typically, we're going to tell people when we start them, especially if they're elderly, hypotensive, or it's just to seem to be a little weak, debilitated, that when they first start taking the drug, to be cautious when they're getting up. We're worried about a little bit of orthostatic hypotension. Same thing with as we had with the M tablets. The Zydis tablets are very fragile, and basically these can be shouldn't be pushed through the foil and should be kept in the foil blister pack until ready to use and taken out immediately for that. So again, the advantage is because it's an atypical, we do see potential effects on positive and negatives. We can get by in some cases with once a day dosage. Some people, you've got different people that will argue that one of these is a little less than the other ones. Olanzapine does have a long half-life, and one of the biggest disadvantages of olanzapine is right here, weight gain. Oops. This is one of the big things that a lot of people worry about, because people can put on quite a bit of weight. Now, with all of these atypicals, we are going to be also looking at potential issues associated with some of these other side effects, hyperglycemia, diabetes, and so forth. Quidapine, here we have 6 different dosages. We have extended release tabs. So for a long-term action, one of the things with the extended release is in some patients that helps quite a bit with compliance. With other patients, we may have to tweak it, and sometimes we may use an extended release and then add one of the other shorter acting agents on top of it. So typically they begin with about 25 milligrams twice a day. Increase the dosages, typically 25 to 50 milligrams. That usually is on the second or third day. You want to go maybe a little bit slower in, again, geriatric patients or people that may have debilitations. And also people with liver function. That's pretty much a standard for most of these drugs here. And so it's one of those things where just with schizophrenia and psychosis, sometimes we do see individuals trying to push the dosage quickly and can get into some side effects. Can be depressant, be careful with other CNS depressants. And then we do see that phenytoin, which is an anticonvulsant, and thioridazine, which is a typical antipsychotic, can actually increase oral clearance. So basically, you may get a subtherapeutic response because it's getting through the thing. One of the things, the patient counseling is pretty much be careful when you're first starting, and especially if you're, have a debilitated or older patient. But the other thing, and this is true for any of them, is anytime you have a extended release tablet, I think I mentioned this to you guys before, but anytime there's an extended release tablet, whether it's CR, XR, XL, SR, anything that indicates extended release, slow dissolving, controlled release, you don't want to crush those tablets. You don't want to break the integrity of those tablets. Even cutting them in half can, because what happens is that the technology to give it the extended release basically is going to, when you disrupt that, then what's going to happen is you're going to get a greater release. So you're going to get a higher dose than what you would intended to get. One of the things you always have to do with these extended release tablets for most drugs tend to be a little bit bigger. And one of the things that patients need to be told, and pharmacists should tell them also, is what you need to make sure that there's a situation is the patient needs to be, it needs to be told to them that if they're having difficulty swallowing the pill, they can't break it or crush it. That's the biggest thing we usually run into. Advantages, notice there's a common theme here. Effective for positive and negative symptoms. This drug has actually been pretty good to use in Parkinson's disease with people that have psychotic reactions. So that means that, one of the things is that it has a low incidence typically of extrapyramidal symptoms, and so you may not make it worse. Also, we've seen this drug used quite a bit with the elderly or geriatric. Typically, this one may not be what we start off with. It's usually a second line. And one of the things that you look for is this one can cause some changes in the eye. So one of the things that you want to do is about every 6 months when people are on this is have what is called a slit lamp ophthalmic exam to see if there's any cataracts or things like that developing. It is, at one time, people were thinking it was good for treatment-resistant schizophrenia, and really it hasn't turned out to be that. So there was some older literature that suggested that this may be the case. Let's see. So with the drugs that we have now, what we find is a lot of the atypicals, they really have pretty similar efficacy. You will see a little bit of changes, but and some may be a little bit better in one patient. But generally, the positive symptoms are going to have about similar efficacy. We're going to find that they do have some degree of efficacy on negative symptoms. As far as the positive symptoms, they're as good, if not better, as the conventional agents. So from a standpoint of, in most cases, these drugs will work as good as the conventional agents, but they have the advantage of having more of an effect on the negative symptoms, and their safety profile looks a little better. Some people say risperidone may be a little bit more activating, less sedating. I've seen it, patients with, that this may not necessarily be the case, but a lot of people think that risperidone may be a little bit more activating there. So Rebecca, is that it says, so you would not use first. It is typically considered a second line agent, but there may be an instance where you might want to use that with a particular patient, but typically it's used as a second line agent. Okay. Some people argue that with risperidone, that even with some of these drugs, with these these atypicals, some people argue that they may still produce this, that they don't produce any of these side effects, but there is a potential. You have to keep that in. All have potential cardiovascular effects. We always have to worry about orthostasis. That's going to be one issue that's going to be there, drop in blood pressure. We also got to worry about, we haven't talked about it yet, but QT interval prolongation, which we'll talk about this afternoon. Okay. And Joy, that is not an uncommon observation. A lot of people started using risperidone and have used risperidone quite heavily. And in fact, there's been lawsuits with risperidone. One of the things that we've seen is you've seen basically eating disorder and weight gain, the lactation thing, and also what we've seen is, remember there was a pretty long-going law case about gynecomastia, which would suggest that with risperidone, and that occurred in young males. So, so there were a lot of males that developed, there was a significant number of males that developed that, which suggests if it's producing gynecomastia, that is basically suggesting that, yes, it is working on that system. Okay? All right. Now, fixing to go to another drug, but let's stop right now and let us take a look at your case study. So, and again, there may be more than one answer to this case study. Really, it comes down to um, in looking this. So Arnold, if breastfeeding, many of these drugs, I don't know how much has been measured in breast milk, but most lipophilic drugs will actually go across the, um, will go through into the breast milk. And just a second, I will be able to tell you if we have any. So while I'm looking this specific question up, if you guys will get your case study out so we can talk about that. And so with lactation, basically what it says, caution advised while breastfeeding, no known risk of infant harm based on limited human data. So it really hasn't been checked, but being lipophilic, generally most of those drugs will get across to the into the child, but there's been no direct correlation or anything like that. All right, so basically, let's take a look at the case. And so what I gave you was some information. And so your assignment was basically develop a SOAP plan for TM. And I don't want us to go through the specific subjective and objective forms of it. But what I really want to do is in developing the SOAP, you should have come up with regard to what would be your plan, your goals of therapy. So what I want to know is, I'm not so interested about doses right now, but what I want to know is, what did you guys choose to start TM on? What medications? When we looked at his, basically, did we have? Yeah, okay. So what medications? All right, so we have an Abilify. Does anybody have anything other than Abilify? So generally you want to start with an atypical. All right, Rebecca, you felt like you needed a detox. We got an olanzapine and Abilify, generally typical. Chaotic, Risperidone, olanzapine. Okay, Carmen, you had a question about you said there was a question about the diagnosis, Risperidone. All right. So let's start with Carmen. What is your issue about the diagnosis? Okay. So a question about whether this was truly schizophrenia. One of the things may be is that we may need to go back and assess whether that is. We do have substance abuse. We do have a family history of substance abuse. And it's true that, as Rebecca, you're saying, it's true that some of the symptoms could be due to the alcohol. And that is very common in schizophrenia. So we know that that's going to be a comorbid condition that we're going to have to deal with. All right. So, and then Mateo, you made previous diagnosis of major depressive disorder with psychotic features. Okay. All right. So let's say that for our discussion that he does have schizophrenia. Okay. So with these, and some of these things you're talking about are going to be the barriers that we have. All right. So we all agree, pretty much everybody agreed that we're going to use an atypical antipsychotic. Okay. So with an atypical, so we have on the table listed here is basically we have Abilify, we have olanzapine, and Risperidone. I think that's all the ones that we had. Was there any other ones that I missed? So let's just go. So from Abilify, what was the basis of choosing Abilify? Those of you that chose Abilify. What was it that stuck out with Abilify over the other drugs? Okay, it's effectiveness. Janelle, you put effectiveness. Anybody else have anything else? So we're going primarily with efficacy. Okay. All right. So we had Risperidone. So with regard to Risperidone, what was the basis? Okay, and so Janelle, you're also saying that it's available as an injectable as well. Okay. All right, so Carmen, you like the minimal sedating aspect of it. He would have to avoid alcohol. He's young. Okay. Anything else with risperidone? Of course, one of the issues you could be making the case, well, this drug, you need to avoid alcohol. But you got also, what if he doesn't avoid alcohol? That may be another issue there. Okay, so then the third choice, let's see. Kristen, that is an interesting thing. The point becomes with, I know that I've heard this too, is that the question of quote resetting to baseline, but when you look at the when you're getting somebody into sobriety, you got to realize that again that their neurochemistry is they're not cured. So there's going to be some changes that may not be there. I've seen some students over the 30-something years, especially in the students that I've seen them lost from with sort of taking that approach, is that the idea is that sometimes what they try to do is a situation of trying to keep them in counseling and not use medication. But I've got really, I can understand the basis for that statement, but I'm not sure that they really reset to baseline, because we do know if you look at the SPECT scans and so forth that we've seen, we've got a big issue associated with these neurons, that there's changes that are long term, and we don't know how long term. And in fact, we know, like with, for example, some of these substances, like with some of the stimulants, we know that, you know, basically 14 months after abstinence, some of the studies I've seen, they're negative. I mean, that there are basically still some changes that are there. So I think, you know, I think you have to, I don't think you can change, I mean, not go with that, in my opinion. The drug screens have been negative in the ER. That's a good point, Brady. One of the issues that we have to deal with the drug screens is, keep this in mind, is we don't know. So for example, with the ER, we know that there's limited testing in the ER, and it may also be a situations, it may also be a situation where that he may not have been using close to the time of the ER. So that's another issue that can come into play. So my gut feeling would be that the drug screens negative in the ER may be due to either him using a drug. We've seen a lot of it where that people will use other drugs so that they don't test picked up from there. And Jason, you picked up, my next question was on the olanzapine, more sedating, and he seems to be prone to agitation because of his paranoia. So what we're looking here, and you guys have already touched on several key points. There's not necessarily one best answer here. What I wanted to see was the rationale for why you chose those particular agents, and all three, there's a rationale for that that you could follow. You've also identified in this discussion so far some interesting barriers. So what we're looking at is, one of the things I wanted you guys to identify is basically, you know, with the goals of therapy. So if we were to outline the goals, what would they be? Just very bullet point goals. What's your goals of therapy with this guy? Reduce positive symptoms. Take care of the substance abuse issue. Okay. Improve the negative symptoms. Reduce the psychosis and the paranoia. All right. So we have, so we see several, all right, so, and prevent suicidality. So we have goals that can be measured. We have, with each of these drugs, the idea we would look to see, and again, one of the things is with this guy, we don't know from a standpoint of how he's going to react to any of these drugs. Excuse me. So the bottom line is, we're going to have to, we may have to find the right dose. We may have to tweak some of these. We got to figure out, when you look at the barriers or pitfalls, these are things that we got to deal with. Is basically, can he tolerate the drug? Is he going to stay sober? Is he going to follow up with the and let me preface with all of this is when we're talking drug therapy with this, that is in addition to counseling. Okay, I am a strong believer that when people are on drugs, they have to have counseling too. I'm not one of these people that believes you just put people on the drugs and don't worry about the counseling. So this is you're looking at some potential issues here. You've got some clear goals. You've got the issues. Depending on the drug, you may have to counsel about alcohol use. You want to counsel about any CNS use. We got to worry about whether we'll have the pitfalls include what side effects and so forth that we are going to have, and that's going to be an interesting scenario. So these are things there. We may find out initially that the drugs are going to work. So what issues should we discuss with his family, assuming that he's given us permission to talk with his family? And one of the things that I want you to be aware, if the Wellbutrin, Jason, the one of the concerns is going to be, there's going to be two concerns. One is going to be, will we produce too much sedation, even with Wellbutrin? And the other issue could be, effects on blood pressure and things like that. So that's confirmed. But it is not out of the question. Let's put it that way. Lorazepam would be an interesting one, Kara, too. We mentioned that one before. So one of the issues is that, when we're looking at this, we need to make sure the family or the caregivers understand what we're trying to do. Okay. They need to be in there so that we can get them involved with this, and that they can help with the drug monitoring, basically with drug compliance and so forth. So we need to do that. We also need to explain to them that, that these drugs, as we're starting them off, that there may be, some sedation, there may be some side effects, and we need to know about them so we can address them. We also need to let them know that they can't be enablers with regard to the substance abuse. The other things that we see is we need to know from them their perspective as to whether he is responding well to the drugs. Don't forget that the family can be a good source, but also remember sometimes that family members, caregivers, may not want their family member on an antipsychotic. And I'll try to give you some information, Janelle, on Lorazepam before. I think I've got some slides at the end here, as it was a relatively new one there. So we'll pick up on that one in just a little bit. So these are things that we want to be aware of with regard to these. We need to tell the family that this is not going to be a rapid cure. We need to tell them things to look out for, and we need to also be aware, is he taking his compliance? You guys have touched on these. So these are all issues that are going to happen. Okay. All right. Good job with this. Now I'm going to throw another wrinkle at you in just a little bit. In fact, let me go ahead and tell you what's going to happen so you can let me just put it on the chat board, and then I'm going to lecture some more and give you, when you take your break in a few minutes, you'll have a little bit of time to think about it. So what we find is that, let me just tell you what's happening. So we've started them on the particular drug you chose. Let's use that. And I know there's differences there. So what happens is he initially follows, or initially is compliant. Okay. And we're all happy. We think we've got it there. But now he has stopped taking meds. Not an uncommon thing that we see. One of the things that's happened He has gained weight, gained significant weight. And he didn't believe. Yeah, these are the things that we're observing. This is what we're getting from him, Eddie. So gained significant weight and doesn't think meds are helping anymore. All right, not an uncommon thing. Can't, difficulty maintaining a job. And being involved socially. So he's not fitting in with his friends. So his girlfriend has basically encouraged him to come back to see you. Still has paranoia. Okay. So from a standpoint of that, let's do this. Since I just gave you that, let's go ahead and finish this out. So what I want you to do is we're going to go ahead and we're going to take our break. This will be our last big break in the afternoon. So let's come back at 10 after the hour. And at 10 after the hour, what I want you to do is to tell me how you're going to address this. With these new developments, what's the next treatment plan? Okay. And let's see what we can come up with. So let's return back with at 10 after the hour to have a brief discussion of this. And then I'm going to go into, we're going to cover some more lecture with some more material. Okay. So we'll leave the chat board up so you guys can see what's happening here. That the individual was originally started on olanzapine, and what we found with this particular case is basically one of the issues that we found is that he probably with this particular patient is his biggest thing was the weight gain. So when he started putting on the weight, he became very self-conscious with regard to the weight. And as a result of that, the point becomes that part of his belief that the drug was not working any good was the fact that he felt like the side effects were really causing more weight gain. Where it was really the weight gain was becoming more of an issue to him, and therefore he felt like the weight gain was not worth it. So therefore he comes to you and says, look, this is not really helping. Well, he's also lost his job. He's also sort of having social issues. And so we have a lot of things here. And the things that we would look at would be, number one, is and looking at different things that that you guys have written, there's several of these that are viable options. One big thing is whether we don't know from what you have here as to how much he understands what the drugs will do. So I think part of this is engaging him and potentially engaging his girlfriend involved in this because he is listening to her. Part of the issues with having difficulty maintaining a job, let's see, did I tell you what his job was? So one of the things that we can find is, depending on what his job was, that sometimes that the individual, by putting on the weight, if he's working outside or doing something physical, it may make it much more difficult for him to do that. Another thing could very well be with his job. When we find out he's having difficulty with his job, we need to find out what's going on. It may be that he's socially withdrawn and he's also pulling back from his job because of his weight gain and those issues there. We do see that the paranoia is still there. So we do know that we need to address that. But one of the big things that we're going to have to do is there's no discussion in the follow-up that we have that whether his substance abuse issue is still going on. So there's a lot of options that we could go with. As one, as we said, and some of you made a comment, is basically he's listening to his girlfriend, so educate her, get her involved in therapy. Another issue that we might be is to talk with him about, I think we're going to probably be looking at changing his drug, because obviously the olanzapine or the drug that he was on has caused him to put the weight. So discussing with him that we can change his drug, or potentially, some of you have talked about using some combination therapy. So really having a discussion with we might go with, a extended release or an injectable or something like that. But one of the big things we're going to do is we need a plan. Okay, so we need to address changing his therapy so we can handle the weight gain, possibly getting that down. We probably would like to engage a nutritionist to help with the weight loss and so forth, get him back down. The other thing is we need to find out why he's having difficulty maintaining a job and those issues. So that's going to come out in counseling, and his girlfriend may provide us some insight into that. We don't have any discussions or from this follow-up. He has not told us about having, a reemergence of symptoms. He's just simply doesn't think it's going to work. So we need to flesh that out a little bit to find out there. But again, I think one of the issues is that we still got the paranoia, so we're still going to handle that. And I think getting him some goals and maybe seeing him a little bit more frequently initially to try to get that going. But pretty much one of the things I liked about your responses about with this follow-up is that you are engaging. Many of you talked about engaging the patient. You looked at options from a standpoint of what other drug therapy can we use, getting him, getting him back to where he's engaged and he feels like there's going to be a plan that can help him. I think that's it. And again, picking some of these drugs that may have lower weight gain would be an issue. Now, the other thing we haven't discussed is, like, for example, we are making the assumption he was started on a low drug for weight gain, a low dose of a drug, and we might have looked to see if the drug had, if we had elevated the drug up. But again, what you guys talked about is these are pretty good options to follow up there. We have seen some people go back to, several of you mentioned about using Haldol, and we have seen some people go back and use Haldol and pretty successfully in handling that. So I think that the options that you guys, you thought through this, and a lot of it is going to be, really getting him to buy in. And, when you're setting up his goals, one of the big things is going to be, let's get you stable, where you're not gaining weight. Let's see if we can get some of this weight off of you, change your drug therapy. Let's talk to you about, again, finding out what the reasons are that he can't maintain a job. Is it his mental disease? Is it the fact that he's gained weight? Is it something else? And we also might need to check to see if there's some other comorbidity going on. So you guys did a good job with regard to this on a very, very short basis. So if we could get the GPs to manage cases as quickly as you guys, because I gave you literally, 8 minutes plus you had your 10-minute normal break, so you had 18 minutes. So you came up with with some pretty good plans with regard to that. All right, nice job, guys. Really pleased with how you responded with that. All right, let's get back, and you guys got to listen to me for a few more minutes. Let me move on. We're going to move to the next. We compared these atypicals, but now let's move to another atypical, which was actually the first one, and this is clozapine. And with clozapine, we only have a couple of dosages here, and so again, I'm not interested too much that you guys know the clozapine dosages and the dosing issues. Again, this is for your information. What I am interested in is for you to be aware of the issues with clozapine. Now, interestingly enough, most of you know this, clozapine is not a first-line agent, mainly because it's sort of interesting. It was our first new antipsychotic, but it is not a first-line agent. It was the first drug that we got that said, hey, we got some different options here, different way to treat, which looks pretty good. But the biggest thing about clozapine has been because of its side effect profile, we don't see it used as a first line agent. However, with there's been, as we've had experience with clozapine, we see patients actually do pretty well, and some people have actually thrown out, well, why don't we think about using clozapine? It seems to work even with all these side effects. And what I think is interesting about that is probably why the clozapine works pretty well and why people are doing pretty well with it is because of the monitoring. Think about it. With clozapine, this is the one drug that you have to monitor these patients very, very closely, okay? The other antipsychotics, we monitor them, but nowhere near what we do with clozapine. So in my mind, I think one of the issues is that the reason clozapine seems to work in a lot of patients and theoretically could be considered a first-line agent is simply because the nature of the drug requires close monitoring. So let's look at some of the issues if you do use clozapine. And again, it is not recommended as a first-line agent. So first of all, the maximum dose should not go above 900 milligrams per day, okay? The other thing is that if for a reason we have to discontinue clozapine, typically we're going to taper it down over 1 to 2 weeks. Why would we stop it is one of the big things is leukopenia. Leukopenia is when your white blood cell count, when you get a deficiency of your white blood cells, your leukocytes. So let's say that you get severe leukopenia, we're going to have to discontinue the drug. So what we're going to do is we're going to do this over a 1 to 2 week period. But while we're doing that, we've got to monitor the patient pretty carefully. We got to make sure that we don't have this abrupt recurrence of psychotic symptoms. Or the other thing we can get is a condition called cholinergic rebound, where these people have these, what they get is they get pretty severe headaches, they get nauseous, can have vomiting and diarrhea. So what we have to be is, by tapering them down, we reduce the chance of these cholinergic rebound, and also we can see when, if some symptoms are re-emerging. If sometimes if that occurs, we may have to reinitiate it. And sometimes this may occur only 2 days after, as we're starting to discontinuing it. So we're going to start tapering them down, and we may have to basically reinitiate it because of these symptoms that are occurring. So if psychosis, for example. So what we'll start is we'll go back with 12.5 milligrams, giving it once or twice a daily, and then titrate it back up. There are some significant drug interactions, 2D6 and 3A4 are, of course, our major concerns that we have. I'm trying to change color of the pens here. Give me a moment. There we go. So 2D6 and 3A4 are with most of these agents, but we also see some with 1A2. Cimetidine, that is the over-the-counter acid. You've heard me guys talk about it numerous times. That can elevate clozapine. Caffeine, and we have a tremendous amount of intake of caffeine from individuals. So we have to be careful. Hopefully we would have limited or decreased caffeine in these individuals, but also citalopram as an antidepressant can elevate the levels. Ciprofloxacin and erythromycin are both two drugs that basically are antibiotics. So somebody could get some sort of infection and be put on these antibiotics, and that could elevate the clozapine levels. So we have to be careful there. So we primarily use clozapine for refractory schizophrenia. It's sort of our backup drug. I mean, when all else fails, we put them on clozapine. We do know that clozapine, compared to the other antipsychotics, has significantly less EPS. And in fact, with tardive dyskinesia, we have found that sometimes clozapine will actually help the tardive dyskinesia, and it has been used to sort of treat tardive dyskinesia. So we have seen it used when tardive dyskinesia has occurred. We can put in with clozapine. That being said, the biggest thing, and you guys are familiar with it because a couple of you talked about it the other day, the biggest disadvantages we have is really its adverse effect profile. Okay, we have some agranulocytosis, so we have it attacking, interact with the bone marrow to cause anemias, and these anemias can include deficiency in white blood cells. We have to monitor that. We also see there's a potential for seizures. I'll mention that in a minute. Weight gain can occur. Drowsiness can occur in some individuals. Drooling and hypersalivation. Also cost. It's not the cost of the drug, it's the cost of all the monitoring and everything that you have to do. That monitoring and reporting puts a burden on the patient and on the provider, on the prescriber, because you're going to see what we have to do with monitoring in just a few minutes. And that means the patient has to come back frequently, get bloods done. We find that we're going to taper the drug up. One of the big things is that it can cause excessive sedation, and it can also produce orthostasis. So we're going to taper the drug up. And then we have to taper it off to avoid the things I talked about earlier. One of the big concerns is noncompliance, because if they're not compliant, when the drug drops below a certain level, from them not taking it, then one of the issues happens is you can get some pretty serious side effects, seizures, things like that. Reversal of the antipsychotic actions. So I've mentioned seizures a couple of times, so let's talk about how clozapine basically produces seizures. We've not really talked about seizures being a problem with the other antipsychotics. But what we find with clozapine is that it actually activates postsynaptic GABA B receptors, okay? Those are inhibitory, okay? And so what that does is it actually suppresses pyramidal cell activity. That's part of clozaril's therapeutic action, is by stimulating or activating these postsynaptic GABA B receptors, it sort of puts the brakes on and can sort of be effective in cutting down the seizures and psychotic activity. But the other thing it does is it can activate the presynaptic GABA B receptors. So it's activating GABA B receptors, but it's activating both pre and postsynaptic, okay? So when you activate these presynaptic GABA B receptors, that actually decreases GABA A transmission. So GABA A is going down because you've got decreased GABA release, and that will that can decrease the activation of these postsynaptic GABA A receptors, and that can increase the potential for seizures. So the thing about it is that by activating the GABA A and the GABA B receptors, that can result in increased seizure propensity. So we have to be careful with that. Now, when you look at the monitoring guidelines, they are pretty specific. Pretty much the patient has to agree to do this. As a clinician, you have to agree to do it. So you have to register in actually a program. So before you can actually get the drug, the patient can get the drug, they have to register as a clozapine treatment program. And part of that program means we have to have blood. So what happens is before putting them on Clozaril, we're going to have to take a CBC. All right, and the first thing is that we need to see is that first white blood cell count needs to be greater than 3,500, okay? I'm not gonna ask you these specific numbers, but as far as the number of cells, but basically what we're gonna do is when we start you on Clozaril, we're gonna take an initial blood, CBC. We're gonna make sure that your white blood cell count's above 3,500. Then every week for the first 6 months, so think about it, you've got a patient that's coming in for 24 weeks. Um, Basically, every week coming in so we can get a blood, and we're going to check their white blood cells. After 6 months, they're going to come in every other week. Okay. So what we find is that during any of this time is that if the white blood cell count drops below 3,500, then basically we're going to increase them coming in. We may have them coming in twice a week, or if they're in that 6-month period, they're going to start coming in every week. If that white blood cell count drops below 3,000, then we're going to stop therapy. We got to taper them off. All right. Now we taper them off. Now, obviously, when we taper them off, we're going to try to find something else to manage their schizophrenia. What we're going to find out is we're going to monitor white blood cell count and make sure that it sort of stabilizes. So if it stabilizes, if it gets back up above 3,500, then we can potentially put them back on Clozaril. Okay. But if their white blood cells every drop below 2,000, then they can't go on Clozaril again. That's it. And one of the things by monitoring every week or every other week, the idea is we're going to catch it early. So if we were monitoring it, so if you have a patient that's non-compliant, comes back 3 to 4 weeks and he's below 2,000, you got a problem. So, but Brady, as you just mentioned, this is a huge patient. I mean, think about it. Yeah, you're just getting blood, but you're going to want to see this patient. This may be in addition to you seeing him. Okay. So it's a huge commitment. Some people are not going to want to be stuck. Some people are just not want to, think about in some of these areas or with some of these patients, it may be very difficult to get them in. Now, in many places, you can go where so there may be places they can go and have blood drawn and they can get it done, in the morning or some other time. So they don't have to wait to see the doctor. So that can help. But still, there's a tremendous burden of having to continue to do this. On some drugs, we may want clozapine as example. We may want to do some general monitoring where that we may want to check to see if the drug is there. So in this case, like Haldol or sometimes Prolixin, clozapine, there's some of the others, we may actually request the specific drug to be measured. This may be important for us to get an idea of, are they being compliant? So there's no level that correlates with an effect, but what we look for is to see if it's within the therapeutic range. So those therapeutic ranges would be given. And so if they're being compliant, you would anticipate they're in the therapeutic range. If they were taking too much of their medication, then they would be outside the therapeutic range. If they're not being compliant or not taking enough, you might be below the therapeutic range. With some of the injectable formulations, we may want to take to see just how well that they are, absorbing it from the depot. And you made a point about, you see virtually never see patients on clozapine outside of a correctional setting. It's very difficult in a setting where you don't have good control of the patient. So either in a correctional institute or sometime in some sort of institutional situation. Now, this is just, you're not going to be asked anything on the test on this information, but just to give you an idea. So for example, with haloperidol, we would want to look at a serum level that should be between 5 and 12. Droperidol, we don't see, really it's not useful, but clozapine, we would like to see it less than 1,000, but typically between 350 and 420. Olanzapine, a little bit greater than 9.3 nanograms per mil. Some of the numbers we don't have, some of the drugs we don't have good therapeutic ranges, and people won't use it. The other thing that you may find useful is the half-lives, especially if you're starting to taper and do so. So for example, haloperidol has a 21-hour half-life, but if you're looking at the decanate, the intramuscular injection, basically it may have a 3-week half-life. Clozapine, fairly short half-life, 8 to 12 hours. Olanzapine, 27 to 38 hours. So you can use these to sort of choose or to identify where that you are going to basically when you're tapering drugs on. Remember to have the drug completely out of the system. What you're going to see is 4 to 5 half-lives to get the drug to steady state, 4 to 5 half-lives. So with some of these where you're trying to overlap, what you may end up doing is, waiting till that the drug that's on board is maybe down, you're maybe, 3 to 4 half-lives, and then start tapering up with the other drug. You just have to be careful and watch that pretty closely. Now, many times the drugs alone, and some of you mentioned it with this case we had, many times it's a situation where that you give them the drug and you may have to augment it. So the drug is helping. Maybe the drug isn't getting quite where you want them to be, or maybe the drug is hitting some of the effects, but you may want to target a specific effect that seems to maybe be hanging around. So we've used things like mood stabilizers, antidepressants, and benzodiazepines. The big caution here is with potential for substance abuse. The benzodiazepine is one that you have to be particularly careful of. A lot of times if you're going to use the benzodiazepine, you may be monitoring them. You may want to not give them like a 30-day prescription. You may want to give smaller prescriptions so you can monitor what they're using. Also with these drugs, remember that mood stabilizers and antidepressants and the benzos tend to be CNS depressants. And so one of the things that you want to be careful about is getting too much CNS depressant with what you're looking at. Now, there's been a few drugs, I'm going to put these on. I didn't, that were investigational. A couple of these are sort of interesting. Sertinodol was put out by Abbott, was trying to get it approved. The problem was that the FDA, this is sort of an interesting thing that occurs. The FDA was concerned about the Q2 interval prolongation and the potential for torsades. So here's the thing we ran into. So the FDA actually, the advisory panel voted to recommend approval for a select group of patients, but they never defined what those patients are. And the advisory committee also voted that the drug was not acceptably safe, but it was effective. So their recommendation in this drug did, this is where you get some of the confusion with, you sometimes look and go, why did this drug even get approved or even think about getting approved? And that's one of the things that we sometimes are just absolutely perplexed with. With regard to this drug was not approved, but came close to being approved. And I think they finally saw, well, if it wasn't safe and you couldn't define the patients for it to use, then they virtually came down to saying, well, even if we approve it, it's going to be the last resort drug. And that, in other words, everything works. But, if they, one of the things for FDA approval is that a drug has to be safe and effective. And if you can't approve that it's safe, then why would you even approve it? The reason I put a couple of these in here is just give you an idea of, you may have heard of some of these in some of the clinical trials, but I'll tell you, I saw some of the FDA documents with Lamictal, which we will talk about next week, and I, to this day, am surprised that Lamictal was approved. Now, let me talk to you about a couple of other things. When we see schizophrenics, one of the things that we do see is that these individuals seem to have an increased risk of medical illness in general. We find that even back early as 1998, people were recognizing that schizophrenics had approximately 2 times an increased risk of death from just overall medical causes. And we saw a lot of schizophrenics that their major cause of death was actually some cardiovascular issue. Some of these schizophrenics were being treated. Some of them were not being treated. Some were not being adequately treated. So we do recognize that there is an increased risk in these patients. So there's a good chance we're going to have comorbidities. There's also a good chance that we've got to be careful with regard to the drugs that we're using. The other thing is, many of these drugs we had, as we've talked about before, is these antipsychotic drugs, both typical and atypical, these medications produce a lot of side effects. And what you see, and probably with bipolar patients and schizophrenics, are the two groups of patients that we probably see a greater incidence of polypharmacy. And what you see a lot of times is that these side effects that emerge, that sometimes what you start getting into is this concept of just giving another drug to manage the side effect. Sometimes, and I've seen a lot of psychologists that have recommended that when they've gotten some of these patients, they've actually recommended that we sort of pull all the drugs off and sort of start over, which is not a bad recommendation because it's just been multiple prescribers keep putting on drug after drug after drug, and now you've got a big mess. But what we do find is some of these side effects, we will see anticholinergics used, benzodiazepines used, and beta blockers to manage some of the side effects. Now, there's these algorithms. I'm not going to ask you anything off these algorithms, and I will tell you in all honesty, algorithms scare me sometimes. The reason algorithms scare me is really a situation. Kiara, I will do that. That is a good point. I will try to do that. It's an old habit. So thank you for that. So Kiara brings up a good point. That is that we tend to say schizophrenics and cancers, and it's really people that with the disease. And so that is a good thing. And please, thank you for correcting me and bringing that to my attention, because that is a good point. I can't guarantee you I will break that habit today, but I will try to be cognizant of it. But if I'm not, you just, put a little emoji or something there that shakes your finger at me, so that it'll make me remember that. Okay. So, but thanks for that comment. I appreciate that. So what I was saying with regard to these side effects, these algorithms, the reason I worry about them is because people try to sometimes force the algorithm to work. And the algorithms, you're being trained as a medical professional. Algorithms sometimes get into the point of like almost like a cookie cutter type thing, and this doesn't always occur. So what could happen is this. If someone develops EPS, then one of the things that you can do is give an anticholinergic. And if that doesn't work, then you'll have to try something else, maybe a different drug. And so the problem I have with this type of algorithm like this is with EPS, the first thing is not necessarily give them an anticholinergic. The first question would be to look and see, what drug you're using. Is it possible to lower the dose? Is it possible to pick another drug that may be better rather than just throwing EPS on top of it? Akathisias, we do, and again, with all of these, we find maybe the situation is look to see if the dose is there, see if there's a drug interaction or things like that. Akathisia, propranolol has been used. Then NMS, basically we don't have an antidote for that. And severe tardive dyskinesia, many times we've pushed them on to clozapine. But now we do have a drug which has been used has been specifically used to treat tardive dyskinesia, which I'll give you that in just a few minutes. So the other thing that you see is some coexisting symptoms is what if somebody's agitated and you've got excitement? Well, one things may be you can use a benzodiazepine as needed, or you might use an antipsychotic as needed. If they don't respond, then if they didn't respond to the benzo, put them on it, try the antipsychotic. If they didn't respond to the antipsychotic, put them on a benzo. With insomnia, basically sometimes they've used either benzos or zolpidem. If they don't respond, we see them maybe go to trazodone. Another thing, sometimes you might can find a more sedating antipsychotic. And with depression, we can use a number of these drugs, SSRIs, nifazodone, really had some liver problems, but typically we see an SSRI, venlafaxine or bupropion. So these are just some suggestions of how to manage those. But again, before you pop into starting adding a bunch of drugs on top of something is should look to see if there's some other issue that is there. Okay. Now, earlier I mentioned cholinergic rebound. And so this is called a rebound psychosis, but they can have some nasty symptoms with it. And the dirty antipsychotics are typically the ones that were more likely the typical drugs. We refer to a dirty drug that affects a lot of different receptors. Typically what this is going to be is going to affect the cholinergic system. So one of the things that we may need to do is that typically if we have a drug that's affecting a lot of systems, we need to taper that off. Don't stop it abruptly. So that will usually, by tapering it off, it will usually minimize or completely avoid the cholinergic rebound. When people, on our case, the guy was talking about he didn't like the way it made him feel. He talked about, he put on weight, talked about he didn't think they were working. A colleague of mine shared some of these comments with me here, is that, and this was specifically more frequently a situation where that people were on the typical drugs, but it can still occur with the atypicals, especially at higher doses, that a lot of the patients would describe when they're on these drugs as they were separated from the outside world. I used some quotes that he had from his patients. He said that it's like there was a glass screen and they were sort of separated from them. A lot of people describe that on the drugs, they feel numb. This is when I was saying sometimes that the symptoms while being on the drug may be similar to the negative symptoms. Some people feel like that it makes their life feel sort of meaningless. They just, sometimes these feelings are, you may have where that the positive symptoms, now that they are being pulled down, that these negative symptoms seem to be more prominent, whereas the positive symptoms may have been more dominant. But a lot of these drugs, they do have, some significant side effects that people will describe that they just don't like the way that makes them feel. They do tolerate the atypicals much better, but you still are going to have some patients that are basically going to be complaining of the atypicals. And sometimes by moving to a different atypical with a slightly different side effect profile may work very well. So the EPS, we've talked about that today, and I think we covered some of this, but I want to point out some things to you, and I've got this in red because I think you need to be aware of them. These are typical, I should say, these are some of the EPS symptoms, and again, we see them more frequently in the typical antipsychotics, but we can still see these with the atypical antipsychotics. So let's just take a look at a couple of these, and I've got some of these treatments here, but acute dystonia typically is going to emerge in 1 to 5 days after starting the drug. A lot of times these individuals are going to have spasms of the tongue, the face, their back. The first thing we want to do is to see if it's a dose-related thing, and if we can adjust the dose, that may take care of it, but we can use benztropine or Benadryl. Benztropine is an anticholinergic, Benadryl is an antihistamine, and that can sometimes work. But ideally, it would be better than treating it that way is to see if we can find a drug. And a lot of times moving to a lower dose atypical, or if you're at a high potency typical drug and you move to a low potency or an intermediate, that may help. Parkinsonism, that typically is going to emerge a little bit later. We're looking at 5 to 30 days. We see the typical Parkinsonian aspects: bradykinesia, tremor, difficulty in walking. Akathisia is sort of a restlessness. They feel like it's almost like they're very compulsive, wanting to do things, very anxious. That typically is going to emerge 5 to 60 days. And then our big one is tardive dyskinesia. And the tardive dyskinesia is typically depicting the oral facial dyskinesias. So it's called tardive dyskinesia because think of tardy, meaning it's delayed onset, okay? So typically we're going to see the acute dystonias occurring pretty early, or the earliest in treatment, and then the Parkinson, and then the akathisia can develop, but it may even, Parkinsonism usually is going to develop within 30 days. The akathisia may take 60, whereas the tardive dyskinesia may literally take weeks to years. So, but these are things that we want to take to be aware of. We used to see with the typical antipsychotics, EPS was readily recognized or was known about by everybody. With the atypicals, there's this perception, as I've said numerous times, specifically that there is a situation where that many people think the atypicals don't cause these type of things, but they do. So with these acute dystonias, we see sometimes there's a lot of anxiety, they're sort of stiff. The other thing to watch out for is these can occur not only after first starting the drug, but they can occur after a dosage increase. So sometimes people forget that these can occur after the dosage increase. The person's been on it, there's been no acute dystonias, and they increase the dose, and somebody says, well, they've been tolerating it, but they were tolerating it at a lower dose. And the other thing we can see is that not only does this occur with the antipsychotics, remember we have things like Phenergan and Compazine. These are antiemetic drugs, which they are not thought of as antipsychotics. But you might have a patient that gets put on these when you're also treating with something. So one thing is with Compazine, Phenergan, metoclopramide, these are drugs that are all antipsychotics that can produce these dystonias. And so it may be possible that you've got somebody on a drug, but then they start getting these other drugs there. Typically, the dystonias occur more in younger patients and male patients. We can use benztropine, but again, you want to check and see if we can monitor the dose, or potentially go to an atypical drug may be a better option if we can. We can sometimes lower the dose, the antipsychotic, and then gradually increase it slowly, and sometimes not develop. But some people also will start off when they suspect, especially with these typical drugs, they may start off with an anticholinergic sort of prophylactically, and then drop the anticholinergic after the first few days. The akathisias, one of the things is never to sit down, is the way people talk about it. It's an inner restlessness. People describe it as, I can't sit still. I feel like I'm jumping out of my skin. They fidget a lot. Their hands and feet, they can't concentrate. They just feel like they have to move. They're just got to move. These can be sometimes treated with a benzodiazepine. Again, lorazepam is used, but one of the concerns is with the patients that may have schizophrenia or bipolar, those two groups of patients may be at high risk for substance abuse. So you want to be careful with using a benzodiazepine. The anticholinergics really don't work well. We have seen beta blockers have been used, and clonidine. Both of those have had some success, and you might want to trial those over a benzo. One of the things that you see is sometimes a patient that is on an antipsychotic may appear to be agitated, and what they're actually experiencing is this akathisia. They're just restless and feel like they're jumping out of their skin. And so one of the things is you want to make sure that maybe they're not experiencing the akathisia. So basically differentiate between whether it's the akathisia or it is a part of the psychosis. Let me see something. All right, let's cover this next slide, and then we're going to take our last break of the afternoon. So extrapyramidal symptoms, sometimes it's referred to as pseudoparkinsonism. Basically, we don't get the bodies up in the brain, the deposits in the brain. These are due to effects on the dopaminergic system. So we have resting tremor, we have the cogwheel. We see all the symptoms of Parkinsonism there. A lot of times these patients may have difficulty standing because of these signs. They may have muscle pain that can be pretty excruciating with cramping. Typically, we describe this really as an imbalance that develops between the dopamine and the acetylcholine transmitters. And so one of the things you can do is we can increase the dopamine or decrease the acetylcholine. So one of the things that we see is we can use Benadryl, which can interact with the cholinergic system, trihexyphenidyl or benztropine. Those are usually the way we see works. The amantadine can work, but people develop tolerance to that pretty quickly. People have tried to increase the dopamine by giving levodopa, but a real problem with that is if you give the dopa, you have a good chance of basically worsening the psychosis. So typically, we're going to see something used with benztropine, Benadryl, or trihexyphenidyl. This usually occurs more in elderly women, and usually is going to occur fairly, as I said on the previous table, usually is going to occur within about the first few weeks of therapy. Usually it'll have occurred within the first 60 days typically. Okay, so let's do this. Let's take our last break. Let's come back at 5 after the hour. I'm going to talk about tardive dyskinesia, which will be the next slide. Aiden, I don't know if you want to take the...
Yes, doctor, I'm going to just run the attendance poll.
Okay, that sounds good. I'm going to mute, and I'll see you guys 5 after. Carmen asked is how long can you give the levodopa with little impact or little negative impact? It's going to vary between the individuals, but if you think about what levodopa does in Parkinsonism, is you've got a dopamine deficiency, so you're given the L-dopa, and especially if you're using something like Sinemet, which has got the carbidopa with it, which will facilitate more L-dopa getting across, you're going to elevate the dopamine levels, and so it really just depends on you could be battling, offsetting the antipsychotic, or you could even override the antipsychotic. So that could, that could easily occur once you got to steady state. So probably within just a few days. There are some people that sort of have tried to do that because of the Parkinsonism. But again, you have to be careful if you see psychosis emerging. The question is it due to the L-dopa? Is it due to the Parkinsonism going forward? Okay. All right. So the big disease from a standpoint of the antipsychotics is tardive dyskinesia. Again, think of tardy. So it's a late abnormal involuntary movement. The big thing with tardive dyskinesia really falls in right here. Many times it's irreversible. So what happens is that the feedback loop, as people describe it, pretty much resets so that there is a neurotransmitter imbalance that becomes permanent. What we find is, and these data here was primarily with the typical drugs, that 10 to 20% of patients on an atypical antipsychotic that went for longer than for longer and on 1 year developed signs of, for longer than a year, developed signs of tardive dyskinesia. And then it's pretty much estimated there's a 5% chance each year you stay on the antipsychotic. We also see with this tardive dyskinesia, we see tics, grimaces, sticking out their tongue, lip smacking, problems chewing or swallowing. These are all issues. And people have tried to treat this, and we've really not had a good treatment for this. A lot of times you try to recognize it early before it really develops. People have tried vitamin E. There's been some reports that some people have responded. It's really not looked at as being a really viable. Clozapine has been one of the things, as we saw in the algorithm earlier. Clozapine has been shown to at least reversed to some extent, this in some patients. There was a big sigh of relief when the atypicals came out because people thought that we no longer had to deal with tardive dyskinesia, and that's true. We do know that, that's untrue. We do know that it causes it, it can cause it, but we do know that its prevalence is much lower than with the typicals. So that is there. So for many years, the issue was each case of tardive dyskinesia was really just managed, and it was, some patients responded, some didn't. Here's some pictures. If you haven't seen, I'm sure most of you probably seen videos of tardive dyskinesia. If you Google it, you can see plenty of videos of people with this. Typically repetitive involuntary movements of the mouth, lips, and tongues. Sometimes you can have dystonia of the trunk and limb. And this can be many times a drug side effect. We immediately put that as a concern if it is if they're on an antipsychotic. But it also can occur with Alzheimer's disease and sometimes with people that have strokes. And then this slide here shows a bunch of serial pictures of a woman with oral dyskinesias that has tardive dyskinesia. So what we think occurs, one of the hard things about studying tardive dyskinesia is developing animal models for it. In humans, it is somewhat unpredictable. We don't know when you're going to get it. We know that the longer you're on the drugs, you can get it, but we generally the research has been involved with when people have already got it, trying to figure it out. So what people believe may be happening is that it may actually be a denervation supersensitivity. It primarily can occur with dopaminergic antagonists, and that includes antipsychotics, and metoclopramide can also occur with those antiemetic drugs that I mentioned. It has been shown to occur with antihistamines. That may be due to an interaction with the cholinergic and the dopaminergic systems. People with chronic alcoholism can develop this. And then, as I said previously, Alzheimer's and cerebrovascular disease can also be associated with it. So the theory is that it's a denervation supersensitivity, denervation in the sense that we are blocking the dopamine receptors, so the system seems to be, the body is like, we don't have enough dopamine, so then it makes new receptors. What puts you at risk? And these are things you consider when you're putting patients on these. If they already have an existing movement disorder, obviously, many times the existing disorder is going to be involving the basal ganglia, the nigrostriatal pathway. So if there's already a deficit or a dysfunction up there, then when you are going to use a drug that may cause a further dysfunction, you can see where this occur. We find that peoples with diabetics are potentially put people at a higher risk for this. We discovered this with, in particular, with elderly ladies, diabetics that were being given metoclopramide for gastroparesis. So diabetes, and part of that may be due to maybe some of the neuropathy that occurs potentially. Elderly females are at a higher risk. And then again, if they've had a previous episode, again, a previous episode would mean that their system may be subject to it. And therefore, if we go in and affect the system again, that would be an issue. So what we see with tardive, dystonic posture, Parkinsonian movements, choreoarthrotoid, these are these sort of dance-like movements, automatisms, tics. We also get some depression, and we also can get some pseudodementia that can occur with these, with tardive dyskinesia. Prognosis is variable. That's one of the big things. Once it becomes irreversible, many times some of the symptoms become irreversible. That feedback loop is believed, whatever that feedback loop is there, is believed to be reset to and can't be modified. We do see that sometimes when the drug is withdrawn, that we do sometimes get some symptoms. Sometimes when we increase the dose of the drug, the symptoms go away, but that's difficult to judge because you could also increase it and the symptoms could get worse. Sometimes, even though we're using therapy, the tardive dyskinesia progresses. So the prognosis is really very variable, and that's why it's such a big entity. So one of the first things we used to do is we started recognizing symptoms, we would withdraw the drug. And sometimes that worked. And that would work if we caught it very early. Sometimes we find if they were on a typical drug and it was occurring, we move them to clozapine or some other atypical drug, and that seems to help. Some people have tried drugs that may deplete catecholamines. Those drugs, when you deplete catecholamines, you're hitting a lot of systems, and so that's difficulty. And other things, people have used calcium channel blockers. They've tried to use antiserotonergic agents, tricyclics, vitamin E, baclofen. All of those have been tried, and there's been variable success with those. Recently, though, a drug called Ingrezza, which was valbenazine, was approved, and this is the first and only drug approved for the treatment of tardive dyskinesia. The way this drug works is basically it inhibits what is called VMAT. That is the vesicular monoamine transporter, and specifically the transporter 2. It's effective orally. The net effect is it depletes dopamine, and so by doing that, it seems to work. The problem with this is that it comes with risk. One of the things we see is that it has been suicidal ideation has emerged. We have seen that it can increase the QT interval, so we need to monitor the EKG. It's also metabolized by 2D6, so if there's a poor metabolizer, we need to use lower dosages. So this has been the first drug that has been actually approved for treatment of tardive dyskinesia. This is the side effects algorithms. I've got some duplication slides here, so we talked about this one. We're going to skip it. And let me move to a couple more serious side effects of these antipsychotics, okay? One I mentioned earlier today, which is NMS, which is called neuroleptic malignant syndrome. It is usually characterized by hyperthermia, so their body temperature goes up. There's EPS, and a lot of times they develop autonomic instability. In other words, their heart rate and blood pressure starts fluctuating quite a bit. They can develop a stupor. Typically, we find that their creatinine phosphokinase is elevated. We see their liver function tests become elevated. They develop myoglobinuria, which basically the muscles are breaking down and the myoglobin's being excreted to the kidneys, which is clogging the kidneys. And then we also get some leukocytosis, so white cell involvement. Typically, this can occur with the antipsychotics, and when it occurs, we typically are going to basically use supportive care and monitor the symptoms, like try to use things to lower their temperature, try to keep their blood pressure and heart rate stable. Occasionally, people have used a dopamine agonist to sort of offset the dopamine antagonism, but once that this has been taken care of, basically you don't want to give them, you want to wait at least 2 weeks before you try another antipsychotic, and probably we're going to try to use a different antipsychotic. These antipsychotics can produce cardiovascular adverse effects. We've talked about the anticholinergic effects. We've talked about the alpha blockade, which can cause the orthostasis or the syncope from orthostatic hypotension. And then most of you are aware of this one, but this has been a big one, is prolongation of the QT interval. This is one of the big concerns we've had with the antipsychotic drugs. It's recommended that people, if you're over the age of 50, that you get an ECG, both before you start on it as well as while you are on it. I would suggest possibly looking at an ECG even if patients are under the age of 50, since this can occur. So we get a fairly unique arrhythmia. So this is just an old picture that you guys have seen before, which shows an EKG. We see the P, the Q, the R, the ST. And what we basically are seeing is the QT interval here gets prolonged. And that sets up for, this is fairly easily measured. It can be measured computerized, it can be measured manually. Most EKGs will monitor this. But when the QT interval becomes prolonged, it sets up for a particular arrhythmia known as torsades. Here is what torsades looks like. It's a ventricular arrhythmia. It can be life-threatening, and so that's what we have to be concerned with. When you look at the QTC intervals, there's been studies. This came from a study that was done. It's known as Study 54. So what they were doing is they compared different drugs with their ability to change the QTR interval. So what you see is that over here, thioridazine had a big difference with regard to the change in this. But basically, we saw a lot of the other drugs, ziprasidone, these can all increase the QT interval. And although they're not as bad as with some of the typical drugs, probably ziprasidone is one we would have the biggest concern with, although it has occurred with these others. Now, at the bottom of this slide, it mentions the Bazette correction was used. That is a correction that corrects for heart rate, and that is done by the electrocardiologist. Needless to say, the biggest concern we have is that anytime a drug can prolong the QT interval, it can potentially set up for a fatal heart arrhythmia. One of the things that we worry about sometimes is there are sometimes when people have already prolonged QT intervals. And so if we don't know about that and we put them on one of these drugs, then the prolonged QT interval can make it worse. There's a few other things that we see. Sometimes these antipsychotics can produce cataracts. These are known as lenticular opacities. Mellaril or thioridazine was shown to produce retinosa pigmentosa, which can result in decreased vision. So with certain of these drugs, we may want regular eye exams to try to catch and see if any things are occurring. We may want to ask the patients if they are seeing any changes in their vision. We've talked about the interaction with the tuberoinfundibular pathway, and this is some of the endocrine adverse effects we see. So when you block dopamine receptors, that elevates prolactin, okay? When you elevate prolactin, basically that can produce galactorrhea, gynecomastia, amenorrhea. What we found was risperidone probably was the worst drug to produce that. Olanzapine was probably the better one for use. Olanzapine can still cause some of these conditions, but it doesn't produce it to the same extent as risperidone. Of course, quidapine and clozapine also are lower, but think about this. Clozapine is going to be last resort, so quidapine may be an alternative. So typically olanzapine or quidapine are going to be used for this. But again, risperidone seemed to be the one that produced the greatest effect. Big issue, just as with the case that we talked about, weight gain. There's a lot of things that have suggested as to mechanisms. It's been suggested that, for example, the antipsychotics may act directly on the hypothalamus to stimulate appetite. We do see a lot of people that are on these will say that they're eating. Sometimes they think they're eating because they feel better. We know that when you block the serotonin receptors, that can increase appetite. We know that histamine blockade, that increases weight gain, increases appetite. There may be some other transmitters, but clearly we do see antipsychotics can produce weight gain. And it is a concern because not only do you have the weight gain, which can impact the cardiovascular aspects of the individual, but increased weight can also set up for issues with diabetes. When you look at cardiovascular disease, which comes into play, one of the things that you see here is that when you look at things that affect the cardiovascular disease, when you look at single risk factors, things like increased BMI, smoking, cholesterol levels, diabetes, which is diabetes mellitus, and hypertension, you see the odds ratio of significant problems increase when you start increasing these, making the risk factors multiple. It is not uncommon for us to see somebody that smokes, that is overweight, has high cholesterol, has diabetes and hypertension. And we see significant increases in those factors. So when we have drugs like antipsychotics, which may increase diabetes and weight gain, this can have a significant impact on the general population. When we look at patients with schizophrenia, basically what we find is that some of those individuals actually, so for example, the blue says are patients that don't have schizophrenia. The orange is patients with schizophrenia. And notice when we start getting that over here with the body BMI range, that are when you get to 28 to 30 and higher, that patients with schizophrenia have a higher percent are overweight. So there is something about when you compare to the general population that patients with schizophrenia can have can have greater effects, can actually be more obese. So obesity may be a thing that occurs with the development of schizophrenia. And then, like I said, when you look at drugs with significant weight gain, look over there, olanzapine shows one of the highest weight gains. We see quetiapine is up there, but probably the one with the lowest weight gain, but still has weight gain. You see an increase of almost somewhere between almost 10% with aripiprazole. So when you look at these drugs, what you find is, as far as this table goes, don't worry about trying to mention this, is we see all of these drugs can produce weight gain, okay? Clozapine, olanzapine probably are the worst. When you get down to ziprasidone and aripiprazole, we do see that it can still increase weight gain, some patients not. We also see that there is with the higher drugs that produce the greatest weight gain, we have a greater chance of diabetes and a worsening of the lipid profile. And although the drugs like risperidone, quetiapine, and aripiprazole, those seem to not be as bad, we do see as we've gained more experience that they do still have that possibility. When you look at monitoring, what you're going to see is we want all of these things at baseline. And then with weight, we'd like to measure that. If we measure it every month, then we can pick up changes early and try to offset it. Generally, we're going to, ideally, we would like to monitor these when they first start, maybe at 4 to 8 weeks. That'll vary depending on your patient, depending on a lot of different factors. When you look at weight gain, take a look over here. You can see this was a meta-analysis, and we find that we see weight gain with a lot of these. And this includes a lot of the typical drugs as well as the atypical. But we see over here olanzapine, and olanzapine is one of the worst ones. Clozapine is worse, thioridazine. One of the things about clozapine is you're going to be monitoring that patient closer so you can pick up on some of those weight changes earlier. And that should be the last slide that you guys have. Am I correct? Now, one of the things that I'm going to tell you is that, so in a moment, we're going to give you your quiz for this afternoon, and that's it. But the other thing is we're going to touch on these drugs when we talk about bipolar 2. But one of the things that I really want you to do is, since I will see you guys next week, if you would please also look over, this mechanism with the different pathways. And if you have questions, please send it to me. But we can redo those or rediscuss those next week also. So I'm going to turn it over to Aiden to basically give you the quiz. Before I do that, does anybody have any questions? Eddie, I had to think for a minute when you said, look at the whiskers. I forgot that we call those, I forgot that we call those standard error bars whiskers there. But what we did see with the weight gain is that yeah, we do see people can put on quite a bit. Which when you're talking about the material you didn't get to, are you talking about the different? Let me think of it. The let's see. Let me double check here. Oh, I'm not going to let you go yet. Mine looked like, that's why I was asking, was there any slides? Let me hit some high points of this because we're almost out of time. So let me go on these here. Hematological adverse effect. Thank you for catching that because I thought there were some more slides here. With hematological, we do see the concern with agranulocytosis and aplastic anemias and leukopenias. So that is one of the things that clozapine is the main one we need to monitor for. And there is going to be some of these slides, which I think they're there, which will not be covered in detail, and I will cover those real quick. We'll get to those really quickly. Psychiatric adverse effects, always be concerned about, is the psychosis getting worse, or is it dysphoric, and is that a side effect of the particular drug? That's one of the things you want to consider. From the drug interactions, 2D6 is a big one. We've mentioned that before. And people that smoke, and we do see a lot of people with schizophrenia may smoke, and we can get some enzyme induction with that. Be awful careful about using psychostimulants with regard to these drugs. We've talked about that. I have given you this chart on slides 162 that give you the major metabolism things. Think about carbamazepine, anticonvulsants as being the ones, as I said, that induce it. Don't worry about these drugs, these other drugs that are used. I've got them in red, but I don't think I'm going to ask you any questions on that. Be careful when using lorazepam or hydroxyzine. Be very careful about, you're using them for agitation, but you may have a potential for substance abuse. So very limited use on those, and especially trying to prescribe those to these individuals. I'm going through a few of these things here. All right, these last bunch of slides I've given you, I just want to make a point. When you look at these different consensus statement results, you can look these over. I'm not going to ask you any specific questions on these consensus statements, but a lot of these guidelines, what you are literally seeing with these guidelines are basically, if they're having it, do an atypical. If the atypical doesn't work, adjust the dose or go to a different atypical, and then go to a combination, and then you end up going with clozapine and maybe haloperidol. If you are on an atypical, try another atypical. The problem is that schizophrenia is such a dynamic disease, it is very difficult to come up with guidelines. And in fact, many of these guidelines will have statements that pretty much say these should not be considered standard of care because the individual patients are so different. What we have seen is in the past, basically the biggest issues was EPS and tardive dyskinesia. We were worried about, could the patient tolerate them, and we worried about them developing tardive dyskinesia. Today, we're seeing that these EPS and tardive dyskinesia is not, occurs less frequently, and that doesn't seem to be as big a concern as it was in the past. But at the same time, what we see, the cardiovascular health, the diabetes, the glucose, the weight gain, the old era in the past, we didn't worry about it, never thought of, never really on the radar screen. But today, that's more of a concern. And especially weight gain becomes more of a patient concern. So I've given you, in the end, these different algorithms that you can see. And I've also given you a table, like, for example, if the person, this is slide 178, if the person has got diabetes, you may want to start off with aripiprazole or quetiapine. Those have less issue of creating diabetes. But you can see here are some options, and you guys work through these, very similar to what we did with the case study. But this is a good chart for you guys to use to think about if, you know, if a person has this particular thing, then here's suggested first line therapy, but if that doesn't work, here's some options. The other thing which I do want you to be aware of is the black boxes. So Clozaril has one, haloperidol has one, metoclopramide has one, and general antipsychotics have this thing about the elderly. So I do want you to be familiar with those. And then what we have seen is some of the newer antipsychotics, paliperidone, that's actually a risperidone metabolite. We've got acenapine, iloperidone, and some longer-acting injectables, which are some of the ones we already had. But the question came up about lorazepam, which is Latuda. That is an atypical, so it's going to have literally similar mechanism of action. You can see that their structures are fairly closely related. But what we have here is on the iloperidone, we do see, again, it's a serotonin dopamine antagonist, has a bit higher affinity for the alpha-1 receptors. So we're going to have a little bit of concern there with orthostatic hypotension. Very high protein binding means we got drug interactions. And so I've given you some ideas with those, also with it coming through the metabolism of 2D6 and 3A4. Adverse effects are pretty much what we would expect. And then in the future, we do see people trying to develop these NMDA components, glycine transport inhibitors. These are being looked at as a potential one. And this glycine reuptake inhibitor, I've given you the mechanism here, but I'm not going to ask you anything on it. So what we see is basically what I said with the chart. We were concerned more about tardive dyskinesia and so forth. Now we're worried more about cardiovascular health, weight gain, and diabetes. There's a black box for acenapine, and that's it. So the black boxes is the things that should focus on, because that you should know those for any of the drugs that you may potentially prescribe. Okay. So with that, I will now officially turn you over to Aiden. And if you have any questions on the slides as you look through them and take a deep breath, send me an email and I'll try to respond back to those. So Aiden, I will turn this over to you. The rest of you have the quiz is there. We will post the answers to the quiz. I'll send them to Aiden so he can post them on Moodle. You guys have a great evening, and I hope you have a great week. And I think I will see y'all next week. So with that, have a great day.